one of the newer treatments, Emicizumab, is a product that my grandson uses, and it's a sub-Q injection. And the way it's working for him, and he's just turned 2, is just short of amazing. I'm watching a 2-year-old run around, flop on the ground, run into the walls, jump off the sofa, being a normal kid, and he's not even bruising. This is, I think, becoming the standard of treatment now for many kids, because it allows them to be normal. It allows them to run around and enjoy life. I think the main thing for the parents and for the child is he's not going to go through the trauma of every few days they're going to have to start an IV. A parent of someone who's 2 years old or even 5 years old, it's going to be very difficult to start an IV every few days. This is sub-Q, so it goes in their butt or in their tummy. It's much easier. It's a small, almost insignificant needle to it, so it's much less of a volume that goes in there. It's much easier for the parents, less traumatic for them. Watching my daughter deal with it was amazing to see her growth. So I think if she had to do an IV, it would be a nightmare for her, because it'd be another trip to the doctor. The child would learn to hate that. There might be an acceptance after a period of time with the child, but it's still, you're going in there to get a shot. Never pleasant. So it'll open up, it has opened up for them. Travel and everything else made it easier.
So part of what's really allowed us to inch younger and younger on the prophylaxis are the different treatments that have become available in the last 5 to 10 years. Historically, well, most recent decades historically, we've had factor VIII and IX concentrates, which are IV infusions. Factor VIII has quite a short half-life. It doesn't live that long in the blood. So full prophylaxis would often look like IV infusions every other day, every third day. As we started to expand some of the modified engineered factor VIII concentrates, we got down to twice a week. We started with twice a week for factor IX for those concentrates, and perhaps got to once a week, once every 2 weeks, more in the adult population. So that's quite burdensome. But as we had non-factor replacement therapies that are now available, certainly in the hemophilia A space, those bispecific antibodies, for example, that mimic activated factor VIII that are administered subcutaneously, it's less burdensome in a sense. It's less of a skill to acquire subcutaneous injection compared to learning how to do peripheral vein infusion. So it's really allowed us to provide that prophylaxis to patients much younger. But with that comes additional questions. How is the immune system going to react to factor VIII? That's always been a challenge with exogenous factor VIII infusions. 30% of our severe hemophilia patients would develop inhibitors. Since the subcutaneous option isn't a factor VIII, we don't develop factor VIII inhibitors to that, of course, but we're still going to need factor VIII exposure at some point. How does that modify our risk of inhibitors? And so I think in the back of many parents' head is, well, which is better? Do I start with subcutaneous? Is it better to start and learn my IV infusion skills? What are the options that work well for me? And that sometimes is quite a challenging conversation to have.
Yeah, no, absolutely. I think you're right that, in the past, we really just had, one treatment, which was factor replacement. And I think we're now in a point where for hemophilia A, for adults, we have gene therapy, also factor replacement, and emicizumab, the subcutaneous therapy that you were mentioning. And for kids, we have factor replacement and subcutaneous therapy. But even within the factor replacement now, we've got really 3 categories, right? We've had the standard half-life factors we've had for decades, the extended half-life factors you mentioned that can be given typically twice a week. And now there's, one that Efanesoctocog Alfa that is a once-a-week treatment that, really offers something a bit different in terms of even factor levels than the others. And then, of course, there's the non-factor therapy. When it comes to hemophilia B, we're still currently just with factor therapy, or for adults, there is gene therapy for those who are eligible. But subcutaneous therapies, of course, are coming for those. So I think that's kind of my sort of overview of the therapies that are currently available. And all of this is happening in a short period of time. I mean, God only knows what things will be like even in 10 years. I know the pipeline continues to be quite rich. So emicizumab is a bispecific antibody. What that means is that it's a monoclonal antibody, and it has two different specificities. So one arm of the antibody attaches to factor 9A, and the other attaches to factor 10. And thereby, it essentially mimics the function of activated factor 8, which is to bring factor 9A and 10 into a specific alignment to then generate activated factor 10. And that goes on to generate thrombin. So the advantage of emicizumab is the fact that it is a monoclonal antibody. It can be delivered subcutaneously, as opposed to factor 8, which those infusions have to be given intravenously. Secondly, it has a very long half-life of about 30 days. Therefore, the infusions can be given less frequently. Specifically, emicizumab can be given as a once a week, every 2 week, or every 4 week subcutaneous infusion. And this significantly lowers the treatment burden compared to intravenous factor 8 therapies. As a result, emicizumab has become quite popular for the use of prophylaxis, and it's been shown to be a very effective drug at preventing bleeding. In addition, because emicizumab is not factor 8 and only mimics factor 8, it is just as effective in patients who have inhibitors or antibodies to factor 8 as it is in those who don't. So it can really be universally applied to any patient with hemophilia A, whether they're severe, moderate, or even mild for those who might need prophylaxis, and whether the patient has an inhibitor or not. So it has really a lot of significant advantages over the current treatments. The one negative aspect is that it converts patients to a mild form of hemophilia. So it doesn't really fully convert a patient to normal hemostasis. And therefore, for particularly active patients, we have seen that they do get bleeding events still. And in particular, we have seen in a recent publication issues with muscle bleeds that sometimes can be quite severe. It's not entirely clear why these muscle bleeds are occurring, perhaps even more than joint bleeds, but that does seem to be a bit of a limitation of emicizumab. But overall, that is how it works. The treatment burden is low. For the most part, it's extremely effective. The data that has been published has shown that it's really effective for prophylaxis. And therefore, again, it's been used in quite a lot of patients with severe hemophilia A, even patients with moderate and mild hemophilia that need prophylaxis.
The newest factor 8 concentrate that we have in our armamentarium is Efanesoctocog Alfa. This is an engineered factor 8 concentrate that has 3 important additional components. It has an Fc fusion to change the recycling pattern of factor 8 to help extend the half-life. It also has a component of a D' D3 region of von Willebrand factor, which is an important stabilizing region for factor 8 and helps extend also its half-life. And it also has the addition of X10 polymers that further decrease the rate that it is broken down. This is a really exciting and new factor 8 concentrate in that it's the first that breaks the limitation of the von Willebrand factor half-life and really truly extends the circulation time of factor 8, for the first time allowing the frequency of infusions for factor 8 to be just once a week while maintaining trough levels, the lowest levels in the mild factor 8 range, generally in the 10 to 15% range. This is an IV therapy, so it does require peripheral infusion skills to be able to administer. But compared to prior factor 8 concentrates, which would require IV infusion multiple times a week, or compared to emicizumab, which is subcutaneous but provides only a consistent but mild hemophilia range, this factor 8 concentrate allows us to provide normal factor 8 levels for several days prior to the decline into the mild hemophilia range, and then troughing again in the mild hemophilia range, compared to older factor 8 concentrates where the trough would be in the severe or moderate hemophilia range. So for individuals who are particularly physically active, play more aggressive sports, being able to normalize their factor VIII levels during those highest demand times of activity is likely additionally protective in terms of preventing joint bleeds, preventing other soft tissue bleeds, and overall improving their musculoskeletal health. Again, this factor, while it has a number of benefits, does have the challenge of being intravenous. It has not yet been tested in our youngest patients. So in the previously untreated patients or minimally treated patients, we've had very few factor exposures. Whether this factor product will have a similar immunogenicity compared to prior factor products or less immunogenicity or possibly more immunogenicity has not been well sorted out. Also, the utilization of this factor concentrate for immune tolerance induction for those that already have inhibitors is an exciting prospect, but something that requires further study.
So I think for us providers and really also for parents and for patients, I mean, the choices are getting more and more, and it creates some more complexity in the decision making. But obviously, more options, the better, because for what works and what's ideal for one patient may be different for another patient. I even have teenage brothers where one chooses one type of therapy, like Emicizumab, for example, and the other one prefers to stay on factor, and that's okay because whatever their decisions are, they are specifically unique to that one individual.
Like you said, it gives us a great opportunity to individualize. So not all patients are on the same therapy, but even for a given patient over time, we have the possibility to change therapies and interchange. So what might be an ideal approach to prophylaxis during their varsity sports season in high school may be different from when they go on to get their first job or go on to college. So we actually have the ability to leverage these therapies to tailor based on the current life activities and life goals of the patient. And so it's not that they must choose and are locked in, but gives a lot of flexibility to how we can optimize their wellness over time.
I think the more treatments we have, as you said very well, the more we can individualize things. And that's really going to be, I think, the focus of the future of hemophilia treatment is there's no more one size fits all or no more just one option. And here's your choice. And, too bad.
This is the way we do it.
Yeah, exactly.
So I think as we're both pediatric providers, we think a lot about, like you said, early age treatments, use of subcutaneous therapies and the evolution over time. It'd be interesting to learn, Dr. Baggio, from your perspective, how does that translate into the adult years? So certainly many of the patients that you have more significant joint disease because they didn't have prophylaxis at an early age and are now picking between their professions, their physical activities. They feel like they have a good sense, I can imagine, of their hemophilia and the way they've treated it their whole lives. How are they internalizing some of these new treatment options and applying that to their medical care?
Most of my adult patients didn't have any treatment when they were younger, or perhaps they were able to get cryoprecipitate from their father back in the 1960s. Eventually, they had an improvement in their treatment when plasma-derived factors became available. Unfortunately, most of them contracted HIV and hepatitis C when the more purified factor 8 and 9 products became available. Because of that, they're a little reluctant to be early adopters of new or novel therapies. In speaking with them about new therapies, they're very comfortable with their current therapy. They have been infusing factor intravenously a few times per week for basically their whole lives. And in some patients, it's a very comforting thing because before they do an activity, they infuse themselves, they know they're at their highest level, and then they have more confidence and go to do an activity or to go to work or take a trip or have a vacation. In the patients who are a little younger, in their 40s or less than age 50, most of them have not contracted HIV. So they're a little bit more adaptable to taking new therapies or trying new extended half-life therapies, looking for opportunities to reduce their infusion burden because taking factor every other day is very difficult. If someone has poor IV access, patients are much more likely to go to a newer therapy that maybe has less infusions or even as a subcutaneous therapy. I always joke that when I got into hemophilia, there were 3 products, and that's what partly attracted me to it. So I had to know 3 different medicines. And now there's over 20 different factor 8 medicines, there's several factor 9 medicines, and now there's gene therapy and subcutaneous therapies that makes it much more robust choices for patients. And we discuss those with each patient, and I think this becomes a very personal decision for people. Many of the patients say that they're very used to giving themselves factor. They've done it their whole lives, and there's no reason for them to change. However, we discuss things about what if you only had to do something once a week? You don't have to think about hemophilia every day. And that is attractive for many people. We discussed gene therapy available for factor 8 and factor 9. And the biggest concerns for my older patients is that most of them actually have had hepatitis C and have been treated for hepatitis C, and they're concerned about their liver. And that's because they've had these infections, they've had the medications to treat the hepatitis, and they don't want to lose their liver. They've had many friends who have had liver transplants due to the hepatitis as well in the past, and they've seen what they've had to go through. And they're very protective of the liver. My younger patients with hemophilia are actually more concerned when it comes to gene therapy of needing to get their blood tested every single week and to be monitored very closely in a very intense way, in that they feel like they may not have time to do this therapy over the course of 6 months or a year of this very close monitoring. Overall, the patients who are in their 20s and 30s tend to be more interested in doing gene therapy and getting more information about gene therapy versus my older patients who are now more interested in either an extended half-life factor product or the subcutaneous factor products that many of their other family members are using, or in the case of factor 9, that some of their friends have been on clinical trials and have talked about using kind of these therapies that really prevent them from having any bleeding.
So ultimately, in hemophilia, the real unmet need is we really want to cure the patients, and I think that we still are probably pretty far away from that. I mean, the gene therapies that are approved are making some strides in that direction, but a true cure to me means that the factor level's in the normal range and will be there permanently. And neither one of these therapies guarantees that for any of the patients. There have been some patients who, some years out now, are in the normal range, but that's the minority of patients who received gene therapy. So I think that's still really the ultimate unmet need. And I think the other part for me, and perhaps for you as well as a pediatrician, with respect to gene therapy, is that we're offering gene therapy right now to adult patients, most of whom already have some level of joint disease, which is not going to be undone by the gene therapy. So I think one of the sort of ironies, I call it, of gene therapy is that the patients we really want to treat are the ones that haven't been impacted by the disease yet. In other words, the youngest patients we have who have not had bleeds, who don't have joint disease. I mean, that's really where we want to get the gene therapy in so that those kids can grow up truly normal, not close to normal and not needing to do prophylaxis, but really truly have no hemophilia. Obviously, that's ultimately the goal.
And I think for our pediatric patients, therapies like Efanesoctocog, Alfa, Emicizumab are a vast improvement over the traditional clotting factors that we initially had for prophylaxis. But as you highlighted, Emicizumab does not completely normalize hemostasis. So while it provides a consistent level to some degree, those individuals are still effectively in the mild hemophilia range. So how well protected are they? If I want to go alpine skiing, if I want to play a varsity sport, I think there's still angst for parents, for children and young adults around, is how good is this in terms of prophylaxis and still in the back of their minds are continuing to worry about breakthrough bleeds. And even for Efanesoctocog alpha, certainly right after the infusion, we're able to normalize levels such that if you're heading to the operating room, you're heading to aggressive physical activities, you're well covered. But we still have that challenge of fluctuating levels. So it's only going down in each of the subsequent days. So day 1 compared to day 4 compared to day 7, just before your infusion, you are not the same amount of protected. And some individuals have pretty fluctuating activities and lifestyles, but many of us are quite consistent. So that means from day to day, doing all the same activities, you have a different degree of protection. And so needing to modify your infusion schedule around your sports, around your job, around family activities adds another piece of burden, another piece of thought that people always have to kind of factor in as they're making their calendars, making their decisions. And so it seems small, but it is quite kind of a cognitive burden for individuals who are, responsible for keeping everyone safe.
The one group that's really suffered the most, certainly since Emicizumab became available, is the Hemophilia B inhibitor patients. And there's not many of those, but they're around. I mean, I have 3, and all 3 actually, fortunately in my center, can be on a clinical trial. So they are receiving a therapy that is meant to prevent bleeding, but we know most of those patients don't have access to that. And really, those patients do really, they really do suffer because we don't have really any good prophylaxis option for them at this point. So we're hoping to get there, and I think we're getting pretty close to having something for those patients.